exactly meant by loss of domain in ventral hernia. A few years ago, we didn't have any standardized definition about this, even though we have talked about this complex patient for many years. But 5 years ago, we didn't know what actually was a loss of domain patients. There have been this consensus Delphi report where they found out that an hernia irreducible due to lack of space, primary fascial closure cannot be obtained without doing any extra, or that the closure will lead to compartment syndrome. That was what they found out. So in other words, a loss of domain patients is actually a patient where you're not able to close the fascia without any add-ons. And then they discussed a little how should we report this in our patient report. So if you want to calculate a loss of domain, you have to take it like a percentage of the total peritoneal cavity. So there also been this Delphi study about what is a complex hernia patient, and in this category, the loss of domain are also part of that, of course. So how should we, I would really try to have a picture or an illustration showing how complex this is and how many options we have to treat this patient. So since I'm not that good to make drawings, I asked the AI to how to point that. So they will do a picture now, and just to highlight the difficulties, and if anyone can explain the picture, I will be happy about that. But because this is how it looks like if you want to do a complex hernia patient. So who said that hernia surgery isn't very complex? This is the introduction. Look very much forward to this next segment. Thank you.
Talking about when does risk outweigh the gain of surgery?
Good afternoon, everybody. So yeah, when does risk outweigh the gain of surgery? I think this is the biggest question, because we are not a cancer surgeon here, we are quality of life surgeons, so this is extremely important to have this in mind all the time when you have discussions with your patients, and what are the goal of the patient that you're sitting with. I think Andrew DeBow very beautifully described it this morning. So it is crucial to discuss this with your patient, because in this way you will be able to find out which repair, which approach, what you're supposed to do with your patient. So is it a problem with appearance? Is it a problem for the patient to go to the swimming pool, to the beach? Is it pain? Is it problems with physical functioning? Are they not able to take care of their kids, take care of their work, leisure time? Are they not able to leave their house because of their hernia? Are their bowel function impaired? And is their life at risk at some point? This is both ends of the scale of symptoms that can be with a hernia, with a loss of domain hernia. So I came up, I found this risk calculator matrix, and it is used in all different kinds of situation where you want to calculate what are the risks and the possibilities of the different risks. And if we were to apply this for hernia repair, I would say that the catastrophic so the catastrophic risk here would be death. So the critical here would be compartment syndrome, intestinal leakage, intestinal fistulas, respiratory failure. For the moderate would be surgical site infection, pneumonia, DVT, chronic pain. This is just examples, just to show you what I mean. And negligible symptoms would be something like seroma or very light superficial surgical site infection. And then we have to discuss this with our patients and put them into account in terms of how bad their symptoms are. So we have to play this, and I want to introduce you all to the complication bingo that you can play with your patients. So if your patient has a hernia, and I think it doesn't matter what size or how much loss of domain they have, but if it has low impact on their quality of life, then we don't want to put them into too high a risk by putting them to surgery. We want to be in the green and maybe in the yellow zones. If the patient has a moderate impact on their quality of life, then this may change a bit, and we may even subject our patients in the yellow zones and maybe even in the orange zone, so we can accept a little higher risk, a little higher probability of a more severe or moderate or critical complication. And if the patient has severe impact on their quality, if their bowel function are impaired, if they can't leave their houses due to their hernia, if they have fistulas and needs to be on intravenous food, maybe then we can even accept there is a likelihood of a critical, maybe even occasional catastrophic risk of complications. This is a study done by Frederick and colleagues. I think it's very interesting to put it here because it was a study where they asked 5 hernia experts about their opinion about 50 cases of incisional hernias. The surgeons had more than 17 years of experience, and they were asked about these cases, and there was an agreement for indication for surgery. The percentage of agreement was 50%, and the choice of procedure was 40% agreement, and the best precision was 40% of agreement. So not impressed. Some of the choices that we have to make as hernia surgeons are: do we need to pre-optimize our patients with weight loss, tobacco cessation, diabetes optimization of their comorbidities? Do we need to subject them to preoperative training? Do we do open lab or robotic surgery? Where do we place the mesh? What type of mesh do we use? Should we fixate the mesh? Fixate with what? And what are the post-operative regimen in terms of training? And do we have to subject them to post-operative training? So there's a lot of questions and modalities here. So we use a hernia MDT at our facility, and I think this is one of the things that we can do to prevent our patients from losing in the complication bingo. So also we need to have a lot of knowledge and training. We need to use guidelines to improve outcomes, and we need to have MDTs, as we just talked about, and we need to know our limits and ask for help from friends when we reach our limits. And then risk calculate with patients. There are many risk calculators out there. These are some of them. Thank you. We would like